Get started in just a moment, everyone. Good afternoon. Hi, everyone. Thank you for joining us. I'm sure some other people will be joining us momentarily, but in the interest of time, love to get started because everybody is busy. So thank you for joining us and welcome to today's program. I'm Jamie Seward, Senior Associate Director of Alumni Relations with the Johns Hopkins University School of Medicine. Now, before we start the program, I'd like to acknowledge our sponsor, the Johns Hopkins Medicine Department of Neurology and Brain Sciences. I also want to ask you to ask your questions by typing them in the Zoom Q&A at the bottom of your screen. So now I have the pleasure of turning the program over to my colleague, Jessica Lynn, Assistant Director of Development. Jessica?
Good morning. Thank you all again for joining. I really appreciate you being here as we kick off Stroke Awareness Month. I am delighted to have Dr. Michelle Johansson here with us today to speak about identifying the unidentifiable. Dr. Johansson is a board-certified cerebral vascular neurologist and associate professor of neurology at Johns Hopkins University, and she's an associate faculty member at the Bloomberg School of Public Health. She is a clinician scientist who sees patients in her own outpatient clinic and also does her own research on the heart-brain connection, specifically in regards to stroke etiology. And with that, I will turn the program over to Dr. Johansson. Thank you again for being here with us this morning.
Thank you, Jessica. That was great. Can I just get a thumbs up that you can hear me okay?
Yes, we can hear you, and we see your screen.
All right, perfect. Well, welcome everybody. Thanks so much for taking an hour out of your day on May to join us for something I feel like is really important. When Hopkins reached out to me to give a talk about, stroke and sort of thinking through what would be helpful for people at all stages. So I saw that we had patients who had registered, we had researchers who had registered, and we also had some physicians who are attending today. So I'm hoping that this will both be educational and informative, and that together we can talk about some of the concepts of stroke that I feel like are really important to understand. So the title I picked is Identifying the Unidentifiable, What to Do when the Cause of Your Stroke is Unknown. And so you may be thinking, what in the world is this lady going to talk about? So I'm happy to tell you. So our objectives today is we're going to review the different types of stroke. So for some of you, this may be very familiar material. For some of you, this may be a little bit less familiar. We're going to discuss the importance of identifying a cause of an ischemic stroke. And so thinking through causes and why it is that we do what we do is always something important to consider. We're going to review some of the traditional workup. So for example, exams or tests that you as a patient may undergo or as a physician you may order for causes of an ischemic stroke. And we're going to talk about this concept of cryptogenic stroke and embolic stroke of unknown source. And this is what I do my research on. This is what I'm passionate about. And hopefully it'll be a learning opportunity for many of you who are joining us today. We're also going to highlight exciting research in the field and answer any questions that you may have. So I've left plenty of time at the end. So hopefully we can have a good discussion about some new things that are coming out and then answer any questions that you may have about stroke. So as Jessica alluded to, we're doing this in May because it is National Stroke Awareness Month. And the reason that we care so much about stroke is because stroke impacts a lot of people. And so some of you on this may have had strokes yourself. Probably the majority of you have at least one person that you know who's had a stroke. Stroke is a leading cause of long-term disability. About 65% of stroke survivors suffer from disability. And that's something that I really struggle with as a physician and taking care of these patients is that, stroke is not something that normally takes your life, but it leaves you with disabling deficits. So as a result of that, you may think, oh, stroke is just a disease of people who are 80, 90 years old. And that's not true anymore. About 30% of stroke survivors are of working age. People are living longer, people are staying employed longer, which is excellent news. But also, unfortunately, we're seeing a spike in risk factors that are associated with stroke, especially in the United States and in developed countries. Things like tobacco are making a recurrence now, things like obesity that we struggled with for decades. And this is something that I think surprises a lot of people, the stat that heart disease and stroke claim more lives each year in the United States than all forms of cancer and chronic respiratory disease combined. Now, appropriately spending research money on things like cancer is imperative, right? We want to find cures for these diseases in which we have no cure. But heart disease and stroke together, unfortunately, claim more lives than those two things combined. And so thinking through that, thinking through what it is that we can do as individuals to take responsibility for our own health. I heard just on the news this morning at the gym about being a CEO of your own health, and I like that idea. What it is that we can do to help other people sort of understand the signs and symptoms of stroke, and then what it is that we're doing at Hopkins, and particularly some of the research that I'm involved with, to try to push the field forward so that way we don't stay stuck where we are with statistics such as this. So what is a stroke? So people, if you ask them what a heart attack is, for example, most people on the street have a pretty good idea about what a heart attack is and can explain it. Unfortunately, a lot of people aren't very good at explaining what a stroke is. And so stroke happens when there is a region of decreased blood flow that persists for a period of time that involves a particular part of the brain. Now, the brain is amazing, and the reason that I love being a neurologist is because the brain is unlike any other organ. It's extremely sensitive to perturbations in oxygen and nutrients. So as opposed to a cardiac arrest, right, where you can resuscitate someone, or like having a kidney transplant, for example, you can't transplant the brain, and there's no resuscitating the brain, so to speak, by manual compression. So stroke can be devastating because when it happens, the damage can occur very quickly, especially in some patients that don't have what we call good collaterals or good other flow mechanisms by which the blood can get to different parts of the brain. So simply put, a stroke occurs when an artery leading to the brain or within the brain is blocked or damaged. A transient ischemic attack. Now, this isn't something I'm going to go into too much today, but I get a lot of questions about what a transient ischemic attack actually is. So it's a bane of a cerebrovascular neurology existence because unfortunately, lots of people can be mislabeled with TIAs or mini strokes. When they go to an emergency room, they have some sort of neurologic symptom. People aren't really sure what happened to them, and so they label them with a TIA. If you've actually had a TIA, what that is a transient episode of neurologic dysfunction caused by focal brain, spinal cord, or retinal. Lots of people don't know that you can actually get strokes to the eyeball without infarction. So that means that the body takes over and it breaks down the clot and you return to normal, meaning your clinical symptomatology goes away. Now, normally, most people resolve the definition. The formal definition is it has to be less than 24 hours, but a normal TIA takes between about 5 to 15 minutes. So just yesterday when I was seeing patients in clinic, there was someone that I saw who was saying that they had been diagnosed with a TIA. So we spent a long time thinking about the symptoms, talking about what workup that they'd had done. And the reason that a TIA matters is because if you've actually had a TIA, that could be a heralding event, meaning perhaps it suggests that you're at risk of having an actual stroke in the future. Ischemic stroke is where I concentrate the majority of my research efforts. Ischemic stroke is where there's occlusion of a blood vessel. It can either happen by thrombus, which is like that nasty plaque that can build up in the blood vessels around the brain. It can happen as a result of an emboli or an embolus. Basically, all that means is that a clot from some area of the body has gone to the brain. A stroke can also happen by hypoperfusion. So for example, if someone has a massive blood loss event in the setting of trauma, or if someone is undergoing a prolonged surgery and there are complications, stroke can also happen in that setting as well. Hemorrhagic stroke is a little bit different. A hemorrhagic stroke can happen for multiple reasons. You can actually get bleeding into the site of an ischemic stroke, meaning that there's a clot that went to the brain. It's sort of a soft, mushy material, and so you get some blood around that area. You can also have ruptures of the small little blood vessels here. Those can rupture and lead to what we call an intracranial hemorrhage or a hemorrhagic stroke. And then finally, lots of people are familiar with the feared rupture of an aneurysm. That's a little bit different. That can lead to something called a subarachnoid hemorrhage. That's where you get that horrible, horrible headache. It's usually in the setting of an aneurysm. And then that can also be very dangerous and very devastating. So those are the different types of strokes, and we're going to come back to that a little bit later in the talk. But, you know, if you don't take anything away from this talk, especially for those of you who are not in the clinical field who are joining us today, one of the most important things is to be aware of what the signs and symptoms of stroke are. Okay, this is an acronym that was developed. It used to just be FAST, and then we added the B to it, be fast, because a lot of people don't realize that balance and vision can also be impacted as a result of a stroke. These are a little bit more familiar among the community. So face, if your face looks uneven. Arm, if you have arm or leg that's weak. Speech, if you're having problems getting words out, or even a language deficit, which is called an aphasia. And then time, you know, it's really important to act quickly. And we talked about why that might be, right? It's because the brain in and of itself is very sensitive to loss of oxygen or loss of blood flow. So the damage can happen very quickly. So this is a nice acronym to be aware of. And the American Heart Association and American Stroke Association has excellent information on their website, especially this month during Stroke Awareness Month, if you are interested in getting magnets or brochures or being involved with the community at all. Okay, so just to kind of drill down on this a little bit, strokes, signs and symptoms are, you have sudden numbness or weakness of the face, arm, or leg, especially on one side of the body. And the brain is remarkable at the way it tries to protect other areas of the brain, right? So that's normally why you only have symptoms on one side of the body. Trouble seeing in one or both eyes. Remember, I talked about how you can actually get a stroke to the eyeball. Confusion, trouble speaking or being understood. Trouble walking, dizziness, loss of balance or coordination. That's in a particular part of the brain called the cerebellum, can give you symptoms like this. Or a severe headache with no known cause. Now that can be in the setting of a bleeding kind of stroke. That can be in the setting of a subarachnoid hemorrhage, or that could even be in the setting of an ischemic stroke, is where you get a very severe headache. Now, the symptom presentation of the stroke symptoms is actually based on the affected side of the brain, which is something that I love as a neurologist, is that the anatomy really tells us what sort of deficits patients will present with when they have a stroke. So this was an illustration that I came across that I thought was neat and really explained a lot of these areas. You know, in the cortex, or the outside parts of the brain, are what we call the eloquent areas. And so that's where you get a lot of your higher functioning capacity. And then deep within the brain is more where you have motor control and some of what we call the simpler manifestations of what stroke symptoms can present with. So for example, in the left hemisphere, this is where your language normally resides. Now, everybody's a little bit different where their language hemisphere is, but in general, language is normally on the left side. Number skills, so your ability to calculate, math, etc. Written language, which is why if you have a big stroke in an area called the middle cerebral artery on the left, these things are impaired. Your reasoning or executive functioning, your ability to make higher order decisions can be impaired. And then scientific functions is all resides normally in the left hemisphere for most people. Now in the right hemisphere, this is where music resides, so your ability to sort of intonate as well as to hear music and to give input musically. Spatial orientation, your awareness of what creativity and art means. And then insight can also reside on the right hemisphere. So in general, if someone has a stroke on the left side, these are the deficits that would be involved if it involves a cortex. Someone has a deficit on the right side, these are the deficits that would be involved that involves a cortex. There's always exceptions to the rule, But this just shows you some of the amazing capabilities that lie within our brain. So when we have a stroke, understandably, it can be devastating if they don't have abilities that are listed here. Okay, now when you think about stroke and stroke risk factors and preventing stroke, there are things you can't do anything about. So if you have a very strong family history of stroke, there's nothing you can do about that. You can't change your age. I know people in Hollywood always try to, but you can't. There's nothing that you can do about your race or your gender or having a previous stroke or heart attack. Those are all things that either you can't change or have happened in the past, and so now you sort of have to live with and go on from. However, there are risk factors that can be managed, and some of the estimates are even as high as 70% reduction in stroke risk if you control these things. So high blood pressure, smoking, high cholesterol, lack of regular activity, right? We can all be guilty of this. It can be easy to skip your exercise, but you have to find a love for it. Obesity or being overweight or diabetes, even pre-diabetes. And that all this great information is available on the American Heart Association website. It used to be something called Life Simple Sevens, was sort of a way to remember a lot of this. And then in 2022, we went to Life's Essential Eights. So we split them into like health behavior and then health factors. So in health behavior, you can think about eating better, being more active, making sure you're not smoking or consuming tobacco products, and getting healthy sleep. Sleep has been shown to be imperative, right? We all need more sleep. And then health factors. So how do you manage your weight? How do you control your cholesterol? How do you manage your blood sugar? How do you manage your blood pressure? These are all critical things in this idea of Life's Essential Eights. Okay, so now let's get into the cause of stroke. So just to sort of set the framework, right? Everybody now knows what a stroke is. Everybody knows what the symptoms of a stroke are. Everyone sort of has an idea in general about what the anatomy is. Now, the cause of the stroke dictates treatment. And as we go through the talk, we'll move more towards research and stuff in this area. In general, the way that you think about ischemic stroke is sort of in buckets. Is it a cardioembolic stroke, meaning that the clot came from the heart and went to the brain? Is it a lacunar stroke, which is those very small blood vessels? Remember, I showed you those that can be damaged in the setting of diabetes, high blood pressure, etc. They can cause stroke. Large artery disease. The more common etiology for large artery disease is carotid artery plaque. Some of you may have experienced this before. Other causes. So if you have a vessel dissection, if you have a predisposition to clots, if you have an inflammatory condition, if you have an infection, sometimes this can all cause stroke. And then this bucket called cryptogenic. And we will talk about that today. And that is something that I do a lot of research on and something that I hope to educate you about today. Okay, so how do you identify the cause of a stroke? So stroke workup, essentially this term means a set of diagnostic tests that are used to determine a stroke mechanism, okay? Stroke workup should also include testing you or the one you love or your patients for modifiable stroke risk factors, right? So making sure that the cholesterol is at goal, and there's a whole bunch of guidelines that could be a new talk in and of itself. Making sure your blood pressure is controlled, making sure that diet has been addressed, making sure that exercise has been addressed. I ask my patients these questions every time, right? Because they're modifiable stroke risk factors, things that we can do something about. The American Heart Association, again, has excellent guidelines to help provide a structure for what the stroke workup should be, and you can go on as a patient and access these. And then most importantly, not every person is the same, right? So making sure that you have a clinician who's going to listen to you when you tell your story, they're going to listen to you when you talk about your symptoms, that they're going to ask you the hard questions about these modifiable stroke risk factors, that they're going to look at the imaging and then come up with some sort of idea at least, or a differential diagnosis, multiple ideas about what could be causing the stroke. Okay, so this whole idea of causality is something very interesting, right? How do you determine if something is actually causal? And I've done a lot of thinking about this as have other people who do research in this area. Now, having a risk factor, right, doesn't necessarily mean that that was the cause of the stroke, which is something that we struggle with in medicine in general. Just because something is present or we find something doesn't mean that it's causal in a disease state. So for example, carotid atherosclerotic stenosis, which is just a medical term that means there's plaque in the arteries in the carotid. Now, if you just have no symptoms and you go to the mall and they do an ultrasound to look at your carotids, which I never recommend, and they find that you have plaque in there, we have no evidence to go in there currently and clean it out. None. Okay? That may change in the future, but we don't have any evidence for that unless it reaches a specific stenotic cutoff, meaning it's so blocked that it's looking pretty scary, or the patient has symptoms. So that's an example of having a disease state, but it doesn't necessarily mean it caused a stroke. Now, the amount of other risk factors have to do with the amount of risk that they contribute with regards to a stroke. So some of you who are listening in today may have atrial fibrillation. Atrial fibrillation is where the heartbeat beats irregularly. We'll come back to that idea. Something called a CHADS-2 VASC score is a quick calculator that we use as clinicians to try to ascertain how much risk of having a stroke, for example, there is among patients who have atrial fibrillation. And then the reason that we do that is because it changes the way that we would treat you. If you have atrial fibrillation and you meet a certain threshold of risk, then we would put you on a blood thinner, an anticoagulant, versus an antiplatelet drug. So these are all sort of things that you can see when you're thinking through kind of diagnostic medicine and you're thinking through how you come up with what causes something. These are things that your clinician should be thinking through. Okay, now everybody gets one busy slide per talk. So this is my busy slide. This was an excellent diagram that was put together recently in a journal called The Continuum that kind of reviews what it is that someone could think about as far as test in evaluating a patient who's had a clinical stroke. So starting with CT or MRI, which is brain imaging, if someone has an ischemic stroke, then you decide what it is that you're going to evaluate for. Are you going to get an EKG and laboratory test? Absolutely. Probably low risk test and would have lots of meaningful information. What about an echocardiogram to look at your heart? We'll talk about that today. Now, if it's in a particular part of the brain, maybe you should be looking at the carotid artery. Probably. We normally do that in everybody. Maybe you should be looking at the blood vessels in the back of the brain. That's probably important too. And then if you've identified a cause already based on this testing, then you know what to do. If you haven't identified a cause, then maybe you need to go further. And we'll talk about what some of those tests are to kind of lead you through this diagnostic algorithm. Okay, now I mentioned brain imaging. Technology has just exploded over the past 5 to 10 years in stroke. That could be another talk in and of itself about when we pull out clots, when we give IV TPA, new drugs called tenecteplase. But today we're going to talk more about stroke diagnosis and etiology. So this is an example of a brain MRI. This is what we call a diffusion weighted sequence. And you can see that there's some white matter disease here that suggests this person has vascular risk factors probably. And there's this bright dot here on DWI that suggests that this patient has indeed had an acute ischemic stroke. This is what the flare image of that same person looks like. It doesn't show us ischemia as well, but enables us to time when the stroke took place. So based on imaging and imaging criteria, we can tell you a lot about what's going on in the brain, about when the stroke took place, and some other characteristics that are important. Now we also have a lot of what we call perfusion imaging. So perfusion imaging is something that really started to come to the forefront about 2015. And it looks at the way that the blood is flowing through the brain. And based on cerebral blood flow and cerebral blood volume and some other measures that I have here, we can make decisions about whether or not we're going to go in and pull out a clot, for example, in an acute time period. So there's lots of exciting things that are happening on the stroke treatment space. And so it would not be atypical for someone to order either a brain MRI or a brain CT for you as a patient to consider some of these things. Okay, structural cardiac imaging. So another test that you may have as a patient is something called an echo or echocardiography. I strongly believe in the ability to be able to visualize the heart and to be able to make conclusions based on what it is that we know in the heart, even as a neurologist. So an echocardiogram is an ultrasound that enables us to look structurally at the heart as well as the function of the heart. It can be given with or without contrast, and it can detect many pathologies that predispose to cardiac embolism. So for example, you may have been diagnosed with something called a patent foraminal or a PFO. This is a hole in the heart that never closes. Or sometimes we find infections of the heart called vegetations. Or maybe cancer or inflammation seeding the heart valve. All of these things can be seen with an echo. Maybe you're going to need to have one that goes down the back of your throat. That's called a transesophageal echocardiogram. And there's different kinds of echoes, and they all show us different structural components of the heart. But this is a test that's important. And as I showed you before, it was recommended in that flow diagram of how we think about working up the cause of a stroke. All right, so let's talk a little bit about this idea of cardioembolic stroke. So as a researcher, a stroke researcher, I spent a lot of time thinking about stroke etiology, how we diagnose patients appropriately. And I also do a lot of work in this space of cardioembolic stroke. And the reason that I do is because it's a particularly devastating stroke subtype. People who have cardioembolic strokes have been shown to have a very strong associated with dementia. I do a lot of work in the neurovascular contributions to dementia space. I'm not going to go into that today, but you're welcome to reach out if you have any questions in that area. As people get older, while stroke in general is going down, which is good, we become more aware of how to treat people with strokes. This particular subtype, cardioembolic stroke, actually, we're going to anticipate an increase in incidence as people get older. And the most common cause of cardioembolic stroke is something called atrial fibrillation that I've mentioned before. Now, atrial fibrillation, many people may know someone with this or have a diagnosis themselves. And what happens is that the atrium, particularly the left atrium, is a pacemaker part of the heart. And the sinoatrial node is very important for setting the pace of the heartbeat. So irregular electrical signals disrupt the normal conduction between the SA node and the AV node. So as a result of that, the atrium is fibrillating, literally. So that promotes stasis of flow, that promotes formation of blood clot, and can actually lead to stroke or other heart-related complications. This is a really great diagram that the American Heart Association came up with that talks about the symptoms of atrial fibrillation. So common symptoms include a racing heart, fluttering or palpitations, fatigue or shortness of breath, or even some lightheadedness. But it's important to recognize that lots of people who have atrial fibrillation have no noticeable symptoms at all. So it's important to get regular checkups, right? That's why you go to a physician about once a year. They can do an EKG and they can pick this up on EKG, or they can give you something called a Holter monitor that you wear over your chest. There's even something now called a Zeo patch, which is like a little sticky Post-it note size that you wear for a period of time. Or there's something called implantable loop recorders. Implantable loop recorder goes right underneath the skin, and it can stay there for longer periods of time and gives us more information about atrial fibrillation. It's interesting that actually Caucasian or white individuals are more likely to have atrial fibrillation than Black individuals. But Black individuals are approximately 1/3 less likely to be aware that they have atrial fibrillation. So kind of some interesting stuff going on there. And I've also done research in this area. If you have atrial fibrillation, there are particular medications that you need, like an anticoagulant, okay, versus an antiplatelet drug. So that's why finding out that you have atrial fibrillation is so important. And there's lots of work going on the best ways to monitor this, et cetera. And like I said, if you want to read more about this, the American Heart Association has some great tools for you, especially during stroke month. Okay, so let's move to cryptogenic stroke. So cryptogenic stroke is an area that I'm very passionate about, which is where the cause of the stroke is unknown, okay? It's estimated to occur in about 35% of people, or about 1/3 of ischemic strokes are classified as cryptogenic. So you can imagine that if you don't know what caused the stroke, then how are you going to treat that patient appropriately, right? Because there are certain causes that dictate certain treatment strategies. So if the etiology is unclear, then the implications for treatment are also unclear. And that can lead to an increase in the risk of recurrent events. So cryptogenic, however, is kind of this umbrella diagnosis or this bucket diagnosis. So it can include patients for whom diagnostic workup was not complete, or it can include patients where there's two competing possible diagnoses, or you have a complete workup and they never figure out what the cause is. And this understandably can be very frustrating, right? So if you have a diagnosis with cryptogenic stroke, what are some additional tests maybe that the doctors may order in thinking about what may cause your stroke? Well, one is inherited stroke syndromes. So I am certainly not a geneticist, but knowing that there can be genetic predispositions to some types of strokes are important if you've never found the cause of your stroke. So there's a higher yield if there's family history or multiple recurrent strokes, very little traditional stroke risk factors, or if there's a high degree of small vessel disease on imaging. These are all hints that maybe there's a genetic component here. There are actually one gene tests that can be done for some of these specific inherited stroke syndromes. And then a family history is just critical. If you have a strong family history of stroke, or you have multiple relatives that have had strokes, especially at young ages, then that's all really important information that we should know about. And then some specific genetic syndromes have treatments associated with them, and some do not. So if you're going to have genetic testing in the setting of an undiagnosed cause of stroke, it's really important that you have an understanding of that, right? What would be the ramification for your kids if you have this test done? What would be the ramification for me if I have this test done? So knowing those things when you go in to talk to a physician is a good idea. There can also be an underlying hematologic disorder. These are less common than the more traditional mechanisms of stroke. But while we're talking about strokes that are hard to diagnose, it's important to know about these. So this includes sickle cell disease. So we have a large population of people with sickle cell disease in Baltimore. And there are particular things that we can do to decrease risk of stroke among people that have sickle cell. You can also test for hypercoagulable states. So what does that mean? That essentially means that you have a predisposition to form clots compared to other people, okay? And it's normally not a good idea just to test for all these things in people who are older, who have more traditional stroke risk factors. But if you're a younger stroke patient and you don't have traditional stroke risk factors, and you've been labeled as having a cryptogenic stroke, then these are some of the things that you can think about. There are certain tests that are associated with clots in the veins of the brain. We didn't talk about that today, but you can actually get strokes from clots in the veins as well as the arteries of the brain. And there are other tests that are more associated with stroke in the arteries of the brain. Phospholipid syndrome is something that you can also test for. It's a very specific condition. You have to meet specific criteria for it, but it's associated with recurrent clots. It's associated with pregnancy complications. It can also be associated with lupus. So these are just some things to once again give you an idea about other tests that could be ordered. I mentioned an infectious cause of stroke. So infection can also lead to stroke. So for example, infective endocarditis, which is an infection of the heart valve, which is increased risk in people who are IV drug users. But we can also see infective endocarditis in people who are immunosuppressed. So if you are on medications that suppress your immune system, then you can be at increased risk for this. Cerebral vasculitis is a very atypical cause of stroke. And it normally involves the lining of the blood vessel wall in the brain and can cause inflammation, etc., that can lead to stroke. So infection of the blood vessels of the brain in the setting of syphilis, for example, or Lyme disease, or herpes, or fungal infection, or even TB, can lead to stroke. And you have to be specific in your testing for these things. Now, very rarely, you can get something called primary CNS vasculitis. That's very hard to diagnose. You would normally have to go to an advanced stroke center like Johns Hopkins to figure out this diagnosis, and can sometimes require a brain biopsy. Now, the majority of stroke is due to traditional stroke risk factors, okay? But there are some other causes of stroke that should be considered in testing if you or your loved one has been diagnosed with a stroke and the cause is unknown. Okay, now what if you do all of that and you still can't find a cause of stroke? I came across this quote in a paper and I thought it was great. A stroke of undetermined etiology is the unconventional democratic vote of maximal insecurity. Either too poor or too rich, an incomplete or absent basis to absolve a cause, or conversely, two or more adequate but mutually exclusive causes. It would not be fair to vote for one or the other. And this was in a paper called Time to Burn the Toast, which is great. Meaning, in other words, we really don't know what stroke of undetermined etiology means. Basically means we don't know, and we're not really willing to cast a vote, which can be very frustrating. So if this happens, what are some questions that you can ask your physician? Or as physicians, what are some questions that you can be prepared to answer? What caused my stroke? Everybody should know that, I think. What happens if the cause is not identified? What are we going to do next? Are there ways to determine the cause of my stroke or additional risk factors that may put me at increased risk of having another stroke? What can I do to minimize my risk of having another stroke? I think all of these are very appropriate questions and supported by the American Stroke Association for you or those that you love to advocate for yourself when you go to see somebody with stroke or stroke-like symptoms. Okay, we're going to transition from cryptogenic stroke, now that you understand what that means, to something called embolic stroke of unknown source. Embolic stroke of unknown source is something that I'm passionate about and do research in. ESIS, or embolic stroke of unknown source, is a diagnosis of exclusion, which means you've had all the appropriate testing. It's not that you haven't completed your workup, and you do not have a lacunar stroke or a small vessel stroke. You do not have a large artery stroke or symptomatic carotid artery disease. There's no evidence of blockage and a high degree in a blood vessel that feeds the brain. And there's no clear cardiac source of stroke, but it looks embolic on MRI imaging. And there's lots of exciting work that's going on in this field. Now, why do we care about ESIS? This was a term that only came out since about 2014. So it hasn't been around for too long. It's thought to represent about 20% of all strokes and about a 4 to 5% risk of recurrence, which is not negligible. And so when you think about ESIS and you think about potential causes of ESIS, could it be caused by subclinical or unknown cardiac source? That's a potential. Is it an undiagnosed cancer? Is it a clot from a carotid plaque that isn't quite stenotic enough? Or maybe do you have a hole in the heart, like a patent foraminovalle and a paradoxical embolism? So the treatment for ESIS is still unclear. There's no evidence to suggest an anticoagulant, which is a blood thinner, and there's no evidence to suggest an antiplatelet drug like aspirin. So that's why doing research in this field is so imperative. And so I'm going to share with you some of the stuff that we've been doing here in the Johansson Research Lab, as well as sort of interest you in some other things that have been going on. So one of the things that we did starting back in 2013 is we looked at characteristics of echo. Remember, I mentioned to you what an echocardiogram is. In people who had stroke but did not have atrial fibrillation. People who had atrial fibrillation, we know what to do with those people. We put them on an anticoagulant. So in adult inpatients at Johns Hopkins with an ischemic stroke but without atrial fibrillation, I did echocardiography of those people to look at their heart and to see if we could see what was associated with types of stroke. Simply put, I put this in here for the clinicians who are joining, but simply put, specific markers of cardiac structure and function by echo were associated with cardioembolic stroke versus strokes of other subtypes, which we would anticipate. And similar markers of cardiac structure and function by echo were associated with cardioembolic stroke when including new atrial fibrillation, meaning that maybe there was something about the heart in and of itself that was giving us information about the type of stroke patients were having. And normally when we get echocardiograms, we just look for infection or we look for clot, but we don't really think about the chambers of the heart. And so that's something that we established back in 2013 as being important in thinking about stroke and stroke etiology. So this paper was published in 2019. We showed that echo can be very useful in thinking about the causes of stroke, especially when cause is not known. And we showed that mild changes led to increased odds of cardioembolic stroke and new atrial fibrillation. So then from there, we thought about what's better imaging techniques that we can use to look at the heart and try to figure out how to work up patients who have had a stroke. This is something that was published by Human Kamel et al., who I collaborate with frequently in 2016. And it was a really great idea after that ESUS publication in 2014 that talked about vascular risk factors definitely contribute to all stroke, right? Certainly if you have high blood pressure, that's a problem. But could it be that there's an idea of this abnormal atrial substrate? Remember I showed you that left atrium, about how that left atrium, if it's not beating appropriately, increases your odds of atrial fibrillation, and how that in and of itself can lead to stroke. But maybe there's something about the heart itself, even if it doesn't manifest as atrial fibrillation, that increases odds of stroke. Maybe that's a group who has ESUS. Maybe that's a group who's been diagnosed as cryptogenic. And we should do a better job of figuring out these people. So then we use something called Speckle tracking echocardiography. So I already talked to you about what echo is and sort of discussed that idea with you. Now, for those of you who are scientists on the line, or for those of you who even just remember physics from college, strain and strain rate and speckle are different ways by which we can think about the heart moving in space. So there's stretch and there's shortening. There's movement of the heart as it's stretching and shortening. And so all of this leads to what we call a local myocardial deformation pattern, which basically means the way that the heart is moving in time and space. And understandably, if that's not normal, you would think that that would predispose to clot formation, which could then lead to stroke. So we were able to come up with curves that gave us information about the heart and how it was moving in time and space. We could even calculate volumes. All of this is done with the Speckle tracking echocardiography. That's not expensive, that's not hard to do, but we used it in stroke patients to get good information about the heart. So what do we find? We took patients from Johns Hopkins who had stroke, who did not have an atrial fibrillation, and we applied this echocardiography technique to their heart to see what it was that we could learn. And then we tried to figure out what caused their stroke. Now, you may not be aware that even the chamber of the left atrium has a cycle, okay? So as your heart is beating and pumping in space, there's a period in which the blood is just passing through the left atrium. There's a period in which the left atrium is going to pump, and there's a period in which the left atrium is going to fill. And all of those represent the cycle of the left atrium. It's just amazing the way the brain works. It's amazing the way the heart works, and all of these things, how they work together to provide the blood with oxygen, right, in a way that doesn't predispose you to have a clot. So once again, this is for the physicians who are on the call, and the paper was published in JAHA, the Journal of the American Heart Association. But what we found is that different phases of the left atrium were associated with different types of stroke. So if your left atrium was not functioning during the filling phase or the pumping phase, you're more likely to have a cardioembolic stroke. If you had a cryptogenic stroke, meaning we didn't know what caused it, these markers were not consistently associated with cryptogenic stroke, which suggests that it's not just the pumping that's necessary, but it's thinking through all of the characteristics of the heart in the setting of the patient who has vascular risk factors to come up with a better mechanism by which these people are having strokes. A study that we recently received funding for that's ongoing at Johns Hopkins is looking at cardiac CT. These are some people who are involved with the study. Cardiac CT is a really cool mechanism by which we can look at both the function of the heart as well as any plaque that's in the blood vessels that surround the heart. This is really cool. We had a patient that we enrolled in the study who was a lady who came in with having a prior stroke, had a completely normal cardiac workup, and was admitted for altered mental status, was just confused, was more subdued, was talking nonsense, and the family brought her to the emergency room and said something is wrong with her, even though the patient did not feel like anything had changed. So we got a brain MRI, and sure enough, there was a stroke that correlated to the symptoms. And you can see it's bright on DWI and dark on ADC, and not on flare, meaning that it was an acute stroke that had just taken place. And we would treat this woman with antiplatelet drugs because that's what you would do according to her presentation. However, we enrolled her in the cardiac CT study, and you'll have to trust me on this. This is not the Loch Ness monster here, okay? But this is the left atrial appendage, and this is a clot sitting in the left atrial appendage. So we talked to the patient, we talked to the family, and we decided to put her on anticoagulation rather than an antiplatelet. And you'll see that the clot has now resolved. Okay, so once again, this cause of stroke that we weren't really quite sure what was going on with this woman, but knew she had a stroke, we were able to enroll her in the study, and come to find out we figured out the cause of the stroke, which was a clot in the left atrial appendage. A lot of people don't know that stroke can also be subclinical, okay? And what I mean by that is, if you get brain MRIs, then you show evidence of covert infarcts, which means there's evidence that there's been stroke in the past that did not present with symptoms. This is detected in up to 20 to 50% of healthy people on MRI. And as you see, these increase as you get older, okay? And these can be just as impactful as they likely lead to cognitive decline. So once again, you can see figuring out cause of stroke, figuring out where the stroke is located, all of these things are important in thinking about stroke, and even silent stroke. And now we know that they're no longer silent. I'll show you some research here that we did that's pretty neat. This was based on the atherosclerotic risk and community study, which is a very large cohort study that involves people all over the United States. And we did something called fluor beta pure PET. This is a particular image of the brain that gives us information about something called amyloid. Amyloid is known to be a precursor to Alzheimer's dementia. So many of you know what Alzheimer's dementia is. So I thought, what's going on in these hearts of these people? And what's going on in the brains of these people? So I looked to see if there was a state of atrial dysfunction in these people, and was it associated with changes in the brain seen on PET? And this was among people who did not have dementia and they didn't have any vascular risk factors. We controlled for that. There's an ongoing study that's also looking at ESUS, and this is something that I'm a part of. I put this here just in the event that you'd be interested in reading about ESUS and how you define ESUS using the heart a little bit more. But getting back to that PET study, what did we find? Well, we found that left atrial volume enlargement and a state of atrial dysfunction was associated with an increased uptake in PET, which means that while I can't say that these changes in the heart caused this marker of amyloid to show up in the brain, we do know that people who had this marker were more likely to have this state of atrial cardiopathy. So are subtle changes in the heart sufficient to cause pathologic markers of dementia in the brain? And there's a lot of other research that I'm doing in this area that we don't have time to go in today, and some other great research that other people are doing as well. Okay, so moving toward the end of our talk now. All stroke is not the same. Hopefully I've convinced you of that. And hopefully we've talked a little bit about this area called cryptogenic stroke, and how maybe within this is this group called ESUS, or embolic stroke of unknown source, And maybe by digging into what the heart looks like using advanced imaging, and maybe thinking through the cognitive ramifications of this, we're going to be able to really herald how important it is to figure out what's going on with patients when they have strokes or when they have silent infarcts, so we can prevent it from happening. So in conclusion, determining the cause of an ischemic stroke is imperative because it enables prevention of another stroke. There are some tests that are routinely ordered and others that may be ordered based on your particular presentation or symptoms that the doctors may not be, traditionally ordering on everyone, but should be ordered in your case. And then finally, the heart may provide information about the cause of embolic appearing strokes yet to be identified with more research ongoing. And that's something that we do here at Hopkins. So I want to thank you guys for taking an hour out of your day today in May. Spring is coming, and so hopefully you're excited about lots of things, including National Stroke Awareness Month. We have a lab website if you'd like to read more about what I and my collaborators are doing in the lab. And then this is something that one of my colleagues here at Johns Hopkins shared, and I think it's really excellent, which basically is this idea that your support for our research is hopefully going to lead to your benefit as a patient and for those that you love, and help us answer questions about the disease process. And I think, none of that can happen without some of the stuff that we're doing here. And if you'd like more information about that, you're happy to talk to Angel Terrell, who's also joined us for the talk today. But most importantly, as a patient and as, having family members who have had strokes, as a physician taking care of patients who have had strokes, and this is something I'm really passionate about. And hopefully we can get more and more answers so we can do a better job figuring out what caused someone's stroke so we can prevent it from ever happening again. So with that, I will stop talking and hopefully we'll have some great discussion for questions.
Thank you again, Dr. Johansson. That was some really great information. I know personally, as you mentioned in the beginning, I do have family members who have, suffered from similar issues over the years as well. We do have one question in the chat. It is, how likely are Lamb's excrescens to cause stroke or TIAs?
All right, let me look and see. Oh, Lamb's excrescens. Okay,
yes.
That must be from a physician. Okay.
Yes.
Yeah, that's a great question. So for those of you who may not know what that is talking about a particular characteristic that's seen on cardiac anatomy. For example, with echocardiography or with more advanced cardiac imaging like cardiac CT. So there are some structures of the heart that we don't really know what their propensity is to form embolism. Okay, so for example, that's one of them. There's also like narrowing of the conduits in which the blood flows. So the simple answer to the question is we don't know. The longer answer to the question is that I think it's important for us to find out. Now, there's been some studies to suggest that these particular morphologies of the heart increase your predisposition to forming clots, okay? Or stasis of flow, which means just slower flow through the heart. However, there's not a lot of robust literature to suggest that changing treatment for these patients makes any difference, okay? Meaning that if I see someone who has these particular characteristics in the heart, that you should put that person on an anticoagulant, for example, like a Coumadin or dabigatran or Pixaban or you pick, versus an aspirin or Plavix or an antiplatelet drug. So I would say stay tuned. We're continuing to look at that, and we're looking at those type of structures in our cardiac CT study. As a clinician, if I have someone with an established stroke mechanism who has those cardiac manifestations, I don't get too excited about it because the research is not there yet to change our clinical practice. If, as a clinician, I have someone who I don't know the cause of the stroke, then maybe I would do more detailed imaging of the cardiac system. Maybe I would put in a prolonged monitor for someone who has these atypical characteristics anatomically of the heart. And then I would refer them for a research study, either to be enrolled in one that I'm doing here at Hopkins or to be enrolled in another one if you have this pathology, to help us try to figure out what it is that actually causes stroke. So that's a great question.
Looks like we have one other comment and question. Someone mentioned that they were determined to have a spinal cord stroke back in January of 21. And would that fall under an ESUS?
The ESUS, yeah, exactly.
Yes.
Right, that's what I was talking about, right. So that's also a great question. So spinal cord strokes are a little bit unique in that spinal cord strokes are normally associated with hypoperfusion events, which means in the setting of a lot of blood loss, for example, those people can end up with spinal cord strokes. However, you're right, you can get emboli that come from the body and actually go to the arteries of the spine. Now, an ESUS would be an embolic stroke of unknown source. So that would mean that, for example, you've had a spinal angiogram and they didn't see any evidence of a dissection or a tear in the blood vessel, or they did diagnostic imaging of your back and they didn't see any blockages of the blood vessels that feed the spine. Then I would say, yeah, that could be considered an ESUS event. But, you know, ESUS is more targeted sort of to the strokes of the brain. There hasn't been a lot of research for ESUS in the stroke of the spine, but that is an excellent question. Normally, spinal cord strokes are treated a little bit differently mechanistically because the blood flow around the spine is a little bit different than the blood flow around the brain. There's kind of less arteries feeding the spine. And so as a result of that, the mechanisms are a little bit more narrowed, but that's a great question. And spinal cord strokes are very important and can be devastating.
All right, I don't think we have any additional questions. Thank you again, Dr. Johansson, for joining us on this Thursday morning, afternoon now. And of course, if you have questions, you can please reach out to Angel Tirole listed there. And I'm going to hand it back over to my colleague, Jamie, to close us out for this afternoon.
Wonderful job. I just want to say thank you so much for your time and your talent. And to everybody joining us today, you'll be receiving a follow-up email with a recording of the program and some more information. And we hope you join us at our next webinar. So thanks so much and have a wonderful day.